whoa. That's bright lights. We are going to talk today about a virtual curriculum to instruct, to learn about caring for victims of sexual assault in the emergency department. We have no disclosures. And we have actually a multidisciplinary group here who's participated in the curriculum. I'm Susan Duffy. I'm a pediatric emergency medicine physician at Hasbro Children's Hospital in Providence, Rhode Island, and at Brown. And I'm the medical director of our sexual assault forensic examiner program at the Lifespan system, which is part of Brown.
And I'm Erica Hardy. I'm MedPeds trained, and I do infectious disease now, so I'm the director of infectious diseases at Women and Infants Hospital in Providence. I'm also connected with Brown. I'm assistant professor of medicine and OBGYN, and I'm the director of our follow-up program in both of the largest healthcare systems, Care New England and Lifespan, both in Providence.
So I am Lori Clements. I am a registered nurse. I am a sexual assault nurse examiner, and I am currently the director of the sexual assault forensic examiner program at Lifespan in Rhode Island.
And I'm Amy Goldberg. I'm a child abuse pediatrician. I work at Hasbro Children's Hospital associated with Rhode Island Hospital, professor of pediatrics, and I've been collaborating with Susan Duffy for my whole career at Lifespan around taking care of patients who are affected by sexual assault.
So we have some learning objectives. We are planning to review the challenges in identifying and caring for emergency department patients who are victims of sexual trauma, and then talk about the need to educate emergency medicine teams to provide the best practice care. We're going to outline the development of a comprehensive virtual educational curriculum for EM providers specifically, out of a needs assessment that we provided. And then we're going to understand the complementary roles of how this curriculum and EM providers can work with sexual assault nurse examiners. And then finally, we're going to demonstrate really and talk about the critical importance of incorporating trauma-informed care into any kind of educational and practice. So just for a little bit of an overview, sexual assault is a pervasive trauma in the United States. The current estimates of lifetime experience of a completed or attempted sexual assault is believed to be 1 in 4 women and 1 in 14 men. That's likely underreported in all. The majority of victims of a sexual trauma do not report to anyone. It occurs across all race and ethnic cultures. So it's really, it does not discriminate. There are high-risk groups for sexual assault, and as emergency medicine physicians and providers, we see that they are our patients. Women, about 85 to 90% of victims of sexual trauma are women. Persons who identify as lesbian, gay, transsexual, queer, and bisexual. Adolescents and young adults is a particularly high-risk and vulnerable period of life. And particularly adolescents who are living out of their home. And if we talk about younger people who are not yet in college age, those often are kids who are in state custody. And there's an intersection between trafficking and sexual assault that is very, very prevalent, that runs through many of these groups. Persons who are involved in relationships where there's domestic or intimate partner violence, I think we're all aware of the co-relationship between sexual violence and other forms of intimate partner violence. Substance abuse disorders actually make patients particularly vulnerable and also involved in trafficking. Patients who have, or persons who have medical or mental health disabilities who really aren't necessarily able to advocate for themselves. And then those who are there are disparities in society to begin with, such as undocumented immigrants who have the least in it for them to report a sexual trauma. They are our patients in the emergency department. In 2019, there was a study that showed 55,296 sexual assault violence-related visits. They increased 1,533% between 2006 and 2019. If you think about that, why? It's probably has to also do partly with reporting and also the evolution of sexual assault nurse examiner and forensic examiner programs, where there is increased recognition because there are other partners to care for this very, very high-risk population. If you think about patients who come into our emergency departments, when sexual violence is mentioned, unless you're equipped to deal with it, much less likely to follow through with the complaint. And in enough time, because patients are so ambivalent, they're less likely to really follow through themselves. And then increasing trends in all females ages 10 to 19, overall what's attributing this increase, but particularly females who are ages 20 to 29, and also an older population of females between 50 and 59, we're seeing increased prevalence and incidence. So how do patients present? They're often ambivalent about seeking care. There's really often nothing in it for patients to report sexual violence. They often come because of medical concerns. They're concerned that they're going to get a sexually transmitted infection. They're concerned that they're pregnant. They're concerned that there's trauma. And they're also concerned about their own safety. It's very, very rare that someone would be arrested based on a sexual assault complaint that comes to an emergency department, even when it's reported to the police. So that's a very, very important thing for us to think about in emergency departments, because are the acute safety issues. They have a variety of complaints, and patients may not report sexual trauma unless they feel safe and supported. And then they're present with the higher risk complaints for sexual assault, such as intoxication or bodily trauma associated with substance use, suicide, other mental health complaints, and acute exacerbations of medical complaints. The EDs are known to be primary point of contact for many victims. So it's sort of ironic that EDs are often the least prepared to care for this population. But with the development of sexual assault nurse examiner and forensic examiner programs, it's really elevated this conversation and improved the care exponentially of this population of patients. There's greater than 400 SAEM and SAFE programs across the US, highly effective, but SAEMs are not always available, particularly in rural areas. I can say in my state of Rhode Island, our state of Rhode Island, we did not have a SAEM program until 2 years ago. Not all EDs are equipped to provide comprehensive services. Sexual trauma victims are complex and have other medical problems, and so it's in the context of multiple complaints that makes it a very difficult population to care for. And it's not a routine part of EM residency. And so therefore, and because it's sort of a double-edged sword, sexual assault nurse examiner and forensic examiner programs have elevated the care of patients, yet it's moved away from, oh, well, this is still our responsibility as ED providers to care for this population. There are national standards for best practice. The Department of Justice, from the Violence Against Women Act in 2016, developed a national protocol for forensic exams. There are training standards, national training standards, that were developed in 2018. And then the American College of Emergency Physicians in 2013 published guidelines for the evaluation and management of sexual assault. And there's some discussion about revising that recently. All right, I'm turning to Erica.
So let's do some polling. Let's try it here. If you either put on the QR code, it'd be nice to actually practice, though. This is low pressure. In case the polling doesn't work, we'll just raise our hands. So once you're all set, perfect. Once it says all set, you should be all set. Good. Okay, let's go on to the next slide. On Menti. All right, so have you had training in comprehensive medical and forensic care of ED patients with sexual trauma? And then don't forget to click submit. And some of us may vote up here too, just to practice. Okay. Great, I think that's it. Click ahead on Mentimeter. Great, and what about one more question? How many patients have you provided sexual assault comprehensive care to in the past 3 years? Like if you had to estimate. None, less than 5, 6 to 10, 11 to 20, more than 20. Great. Okay, and don't forget to hit submit. Great, okay. And then we will move ahead on Mentimeter. Click ahead. Good, okay. Now we'll move back over to PowerPoint. And Sue, I think we're going to talk about insufficient training or unique needs of emergency medicine providers. One of the things, the reports we've gotten from emergency medicine providers are that they don't understand the risk factors for sexual violence. I think the slides must have switched. Can we go back to PowerPoint? Move ahead. Yep, great. One more. Excellent, okay. So EM physicians report that they don't understand the risk factors for sexual violence nor the varying manifestations of trauma presentations in this population. So how might you recognize someone who comes into the ED with a complaint of violence? Some lack knowledge or confidence in providing best practice medical care to victims of sexual assault and collecting and documenting forensic evidence. They might not have the time or training to provide appropriate care and trauma-informed support for victims of sexual trauma. And a lot of EDs, especially we're talking about rural EDs, might lack systems of care that support trauma-informed interdisciplinary collaboration. So we found that there was a real need for targeted education for EM physicians. And so the goal of our curriculum was to train EM physicians and advanced practice providers to follow best practice medical care, forensic care, and support to patients who are victims of sexual trauma and understand the aspects of care and follow-up that will impact patient outcomes. We wanted to train EM physicians in interprofessional collaborative approach, and we'll talk and hopefully have an illustrative case talking a little bit about that collaborative approach to care. What should it look like to improve the outcomes of victims of sexual violence? So we made a medical evaluation of the sexual assault survivor, a virtual educational curriculum. And so I'm going to talk about the specifics a little bit with my portion of the talk. This is online now. It's housed at the Brown CME website. It consists of 8 online multimodal modules. It takes about 11 hours to complete, and people can complete it on their own time. It includes many different aspects. It's multidisciplinary and multimodal, so narrated didactics, case presentations, expert interprofessional interviews. We have simulated demonstrations of trauma-informed approach to the interview, both in the acute medical setting and then in a follow-up visit. And because we're local to Rhode Island, we review Rhode Island-specific resources, but really this could be used to be more general, or it could be specific to your area. We are able to offer 11 AMA Category 1 credits. It's self-paced, and it's intended to accompany an in-person simulation. So what components should be included? If you're thinking about developing a virtual curriculum at your institution, how should you think about, well, what to include? I mean, there's so much. How do we narrow this down? What are the categories? So what we talked about was there should really be some background information. We should frame the issue. We should definitely talk about medical care. This is based for emergency medicine providers or any APP or OBGYN, any provider who works in an emergency setting, and in an emergency setting is taking care of patients who present after reporting sexual assault. So you want to include both acute medical care and follow-up medical care. Advocacy, working with advocates and how should that interface with the care. How to work with sexual assault forensic examiners, and we'll talk about that as well. Evidence collection, it should include details and how to for that. it should talk about the interface with law enforcement and with the medical team, and the legal landscape as well. So those are some of the categories. Where should the information come from? So there are best practice guidelines out there, and you should draw heavily from those. So in terms of medical care, I'm an infectious disease physician, and so worked a lot on the medical STI treatment and HIV post-exposure prophylaxis guidelines. Those have been more recently updated. Department of Justice has a national protocol for sexual assault medical forensic exams. And there's many states have their own guidelines and protocols. We included information from our Rhode Island model protocol for response to sexual assault. You should think about experts in the field that could present on this, both national, local, and for literature, think broadly. We've included some papers, some podcasts to listen to, movies, radio, books, really the sky's the limit, and kind of thinking broadly to keep people's attention. So we'll move over to Mentimeter for the next slide, next poll. All right, so next one. Next one. Might have to scroll through to the next polling slide. Excellent. So this is what's called a word cloud. So you'll type in, we want to see what everyone uses, what resources do you use when you care for a patient who presents to the ED after sexual assault? And we should see the responses come up on the, and it really could be anything. Do you use the STI guidelines? Does your institution have protocols, things like that? Yes. Excellent. Great. Yeah, those are all great. Okay, we'll go to the next, go back to PowerPoint. Okay, so what should the virtual format be? So we used a lot of different things, and I'll talk about kind of studying this as well, but we used case-based scenarios, PowerPoint presentations, filmed interviews on Zoom with experts. We had filmed simulations in our simulation center, multimedia, radio, film, books, papers, and a real variety, kind of which helps with learning and retention. And that seemed to work well. How do you measure knowledge gained? That's a whole field of research, and we're looking to experts to help us evaluate our program too. But how we're doing this, and there's many different ways. There's pre and post testing. You can do that. There's self-report of knowledge gained. There's simulations, SA survivor experience surveys. So have somebody go through the program, survey how they felt. If the providers went through the program, survey how they feel, what knowledge did they gain, how did they feel about it, things like that. So there's a variety of different ways to measure. Also including non-ED information we think is really important. So things with that might be follow-up medical care. What does that look like in your area? HIV and STI testing, medication access, so PEP access, that can be really expensive depending on if the drugs are generic or not, or patient's insurance. It's very complex. How do you handle that in your area? And I think that's important to include. That in the follow-up clinic, this is one of the most important, often is one of the most common questions and something I work on the most with patients. Drug-facilitated sexual assault testing details. So can patient access results? Evidence collection laws. Can patient access their evidence or results from their evidence without the police first wanting to evaluate? That can be different from state to state. What are the legal resources for patients? Law enforcement advocates, psychological resources, crime victims compensation funds, which each state has, and safety planning. All important to incorporate. And then you can study it. So we had beta testing, our curriculum. So initially we did beta testing with experts. People experienced SAFEs who took the modules, gave feedback, and then we made changes based on that beta testing. And then we have the program available in a study format, and we're seeking formal feedback with simulations. And then this program right now is publicly available, and so we have people who can, go publicly onto the website and take the program.
It's free.
Yeah, and it's free, absolutely. So preliminarily, in the study, the inclusion criteria for the study of our virtual curriculum is 3+ years of experience caring for sexual assault victims in the ED setting. Our N, we'd like to ultimately have about 20 providers go through this. We have a pre and post test. They complete the curriculum, and then they do complete a full simulation and evaluation of that simulation. The evaluation includes evaluating them on care of a sexual assault survivor, as well as feedback on the curriculum. Preliminarily, we've enrolled 7. 6 have been complete through the simulation, 3 NPs, 3 MDs, 2 PAAM, and 1 adult emergency medicine provider. Take-homes from evaluation and hopefully learning tips, maybe this will help you all. The simulated video of patient trauma-informed interaction was extremely valuable. Interviews with the detective in the AG office was helpful too, because I think that sometimes EM providers might not see that. Specific tips about the evidence collection kit. Also, we had many comments about it was helpful just to learn how to strategize in a busy ED. Being an ED attending who has done this for a lot of years, how to supervise learners with limited staffing, et cetera. And performing an evaluation with or without SAFE is valuable and needed. So those were some of the things we learned. And since it's been publicly available, about 127 have enrolled from 14 countries, 15 US states, 14 specialties, 23 EM, 12 OBGYN, and then many others, psychology, psychiatry, IM, family, neurology, even oral health cards. So it's been something that folks have been interested in, which is great. All right, so we will move on to Lori.
Thank you. So I'm just going to be talking a little bit about what the SANE and SAFE practice requirements are, and a little bit of the educational component that they have to go through in order to practice. And then the collaborative nature of working in the emergency department with the physicians, as well as presenting a case example to sort of demonstrate the importance and really highlight the need for the virtual curriculum for providers. So back to the
Yeah, we'll switch
polling.
over to Menti, and there's another poll.
So is there a SANE or a SAFE program where you practice? Great.
Great. All right,
Okay.
move ahead. It's going to be PowerPoint.
Okay, so for SANEs or SAFEs, the International Association of Forensic Nursing has developed standards and a framework for forensic nursing practice and education of nurses to practice in this field and work with patients that are PD, adolescent, and adult patients post-sexual assault. SANE and SAFE training requirements require the completion through the IAFN of a 41-hour virtual curriculum. And then they also require a 16-hour in-person clinical skills training. There is some variability across states who have developed their own curriculum. For instance, I am certified in the state of Massachusetts as a SANE because they've developed their own curriculum. And other states have also created their own. This means that the SANE is prepared to go out and practice. They're not certified. The IAFN offers certification exam, but they need to complete not only the education, but at least a minimum of 300 hours of clinical practice in order to be certified. They can then be certified as a PD SANE or an adult adolescent SANE. The curriculum components are similar to what was listed earlier for what was included in the virtual modules, but these are very often the components that you'll see, I wouldn't say this is a comprehensive list, but everything from the scope and standards for nursing, forensic nursing practice, neurobiology of trauma, trauma-informed care, and so on. But I just wanted to highlight here that I kind of highlighted the evidence collection, which seems to be the primary focus when people see these people come into the emergency department. That seems to be the major concern, and although it's important, all of these aspects listed on the screen are very important to the care of the patient and the consideration to this particular case that's in front of you. Additionally, in the clinical training, SAEMs and SAFEs often receive education and clinical practice in head-to-toe assessment, general exam review, speculum exam, and this is primarily for injury identification and documentation, as well as evidence collection. We also, in our program, have incorporated forensic photography and the use of alternate light source training. And then also, we use live models and simulated case reviews throughout this type of training. Ongoing safe and sane education is a must. Depending on the areas where you practice, geographic location, volume of cases that you see can be low. So staying current in the practice is essential. Simulated case exams being offered, opportunities to observe a more experienced, sane, or safe completing an exam, precepted exams, in addition to case reviews and multidisciplinary team meetings is very important, as are annual competencies, just like any other role required. So I'm going to go to a case review that we had recently. Hopefully this will highlight a bit of the need for the virtual curriculum for providers. This was an 18-year-old patient that presented to an adult emergency department in our hospital system. She had no significant past medical history, but she presented for facial burns. That was her primary concern when she walked in. She presented with her grandmother, stating she had no recollection of how this injury occurred. She woke up in her home, was the report, the previous evening, and she had burns to her face, and her family brought her to the emergency department. Later on, when speaking to the physician, she disclosed she had been drinking alcohol, smoking marijuana at a male friend's house the previous night, and then later endorsed vaginal pain and concern for sexual assault. So that's when the physician contacted our SAFE team and provided us with that initial report. So the physician, when the SAFE team arrived, I was on scene with a preceptee, a nurse practitioner that I had on my team. We received the report from the physician. He reported limited experience with caring for sexual assault patients and working with the SAFE program and understanding the process. So what we did was take the time to review what the plan of care would be going forward and how we would communicate throughout the exam. We also discussed, of course, sexually transmitted infection testing, what kind of consults we would need, social work, pregnancy testing, and also the concern for drug-facilitated sexual assault based on the initial report, and that we would circle back to him once we received the patient's history. In addition to that, we addressed our trauma-informed approach, which Dr. Goldberg will discuss a little bit further in the presentation. But part of our program is to refer our patients to either for pediatric follow-up in our child abuse clinic or to Dr. Hardy for our adult patients. So in this situation, what we did was right away encourage our provider in the ED to contact our child abuse pediatrician on call at that time for further guidance and support in his role in managing this case. So this was what was disclosed. within the medical forensic exam to our SAFE team. So the patient did report going to the male friend's apartment, drinking alcohol, playing a drinking game, did not remember any of the events until she woke. She was able to say that she arrived there fully clothed, but then woke up only in a shirt, that they were drinking from the same bottle of alcohol and then mixed it separately in a different drink. She stated that the male looked at her face the next morning when she woke and said, "You should really look at your face," but she was in a hurry and she just wanted to get home, and that she left. She did complain of bilateral tenderness to her upper thighs and groin area and stated they were tender to touch. So even at the beginning of this case, we were able to loop in social work to have a conversation. The patient's parent was present, quite upset, understandably, but we were also able to talk to her about filing a police report. The police came, the detectives were able to kind of talk and support mom, but also support the patient in filing the report. In addition to that, law enforcement coordinated an effort with the SAFE team to have her forensic photos taken by the police officer. So that did happen during the exam. The SAFE also took additional photos after completing the head-to-toe assessment of her face and also her upper thighs. And then the patient did disclose to the SAFE team through the history taking, and again, through a trauma-informed approach, penile oral penetration, oral digital, and penile penetration to her vagina. After the history taking, we were able to circle back to our physician in the ED to talk to him about our concerns of the type of penetration that the patient reported and around injury and drug-facilitated sexual assault. So as you can hopefully attain from this case example, there were a lot of players in this example. There was a lot of coordination from the start, and we, excuse me, we appreciated the collaborative effort of not only the willingness and the openness of the physician in the emergency room to acknowledge that he had a little bit of a lack of knowledge in this care area, but was very willing to work with us going forward to make sure this patient had comprehensive care in the emergency room. So in terms of the virtual training, this provider did express a lot of gratitude, and one of the most positive things that came out of, I think, this case was right at the end of the case. As a care team, the medical provider, myself, and my preceptee were able to go back into the room to sort of comprehensively sum up what the next steps were for the patient, review medications, and kind of move her forward. So the next step would be to follow up with our child abuse pediatrician in the clinic. The importance of increasing the level of understanding about what's involved in the care of patients presenting after sexual assault could be very much improved with the virtual training. It's just helpful for collaboration to have a better understanding of everyone's role in caring for these patients, and just overall increase the likelihood that patients will follow up post-discharge.
So I'm Amy Goldberg. I'm one of the child abuse pediatricians at the Augment Center. And I just want to pick up where Lori just dropped off. And that is that them going into that room and presenting together really helped that patient. And it was definitely a trauma-informed approach that was scaffolded by the creation of this curriculum and the fact that we always have really worked together, honestly, but it's really formalized now. And so that process And just, it seems like such a small point, but I was just sort of thinking about the three of you going back, and Lori had reflected to me that that's not something that had happened before. So that's really important to note, and I'm going to come back to that at the end. So we know that some of the barriers for providers in taking care of this patient population is that, as Lauren aptly said, it's a hot potato. I don't want to do that. I don't want to get involved in that. And so why is that? And one of the reasons, I think, is just this fear or lack of confidence or lack of training that I don't really know what to do and I don't want to cause more harm. And it's really hard. It's just hard stuff. So we've kind of come to that with, well, you need to provide trauma-informed care. And then there's this assumption that we all, as medical providers, know what that is. And it's a term that's just thrown around constantly. And I think if we just asked ourselves or asked our students, they might really not be able to define that. So in creating this curriculum, we really wanted to make it a major component of the curriculum and to really take it on and be able to answer these questions. Why is trauma-informed care important for all patients? So all patients, not patients who are affected by sexual violence, but all patients, and especially when there is a known trauma like sexual violence, and how can trauma-informed care be integrated into emergency medicine education. So really quickly, we're just going to make sure that we know what trauma is. It's individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So sexual trauma certainly falls within this definition, as do many other things, but certainly for what we're talking about, falls within this definition. Do your patients have trauma? The answer is, this isn't a polling question, the answer is very, very probably. We know on the pediatric end of things that 1 in 7 children have experienced child abuse or neglect in just the past year, that by age 16, more than 2/3 of children report at least one traumatic life experience, and that on the adult side, 70% of adults in the United States have experienced some type of traumatic event at least once in their lives. So again, not a polling slide, but maybe you can just nod or something. Do you all know what the ACE study is? Yes, everybody does. I'm going to just talk about it again then with your understanding. And why is it important? The Adverse Childhood Experience Study, which was done in the mid-1990s, really established the widespread nature of trauma for adults, really. And what it showed and demonstrated was that there was a direct correlation between childhood trauma and later events. So not surprisingly, there's association with adverse childhood experiences and mental health problems like depression or substance use disorder, not surprising. But what the ACE study did beyond that was show that when someone has an adverse childhood experience, or 1, 2, 3, 4, which is your ACE score, you're more likely to have physical complications later in life, like cancer, like cardiac disease, like diabetes. And so that was really groundbreaking. And so with this in mind, knowing since the mid-1990s is that trauma is incredibly widespread, and it prompted us as medical providers to start to think about what we do in our interactions with patients to promote healing, to promote better outcomes. And so there's this term that came into being around that time, which was this trauma-informed care or trauma-informed approach. So SAMHSA describes what a trauma-informed approach is using these 4 R's. So realize the widespread impact of trauma and potential for recovery, which we've just talked about, very widespread. Recognize the signs and symptoms of trauma, and just because I have exactly 10 minutes now more, we're not going to talk about that, but we are going to spend some time talking about the how, which is the responding, which is actually what does it kind of look like. And then I'll just touch on resisting re-traumatization. So what does it look like? The trauma-informed interview and exam, which is by the way, something that we included in the curriculum was a simulated interview, which was a trauma-informed interview. And really, when you're thinking about a trauma-informed interview or physical examination, it should include these 4 principles. Safety and support can look like just sitting down first and gaining some rapport with the patient, gaining some trust, having them get used to your voice can start to feel safe, as opposed to coming in and say, okay, let's get started. Not a trauma-informed approach. Finding if they have someone sitting in the waiting room who they'd like to sit next to them, and if they don't, would they like you to call someone like an advocate, as an example. We're really going to talk more about preparation in the next couple of slides, but control, for example, is also really important. When you can offer this patient control, give it to them. So let them move their gown. Use really good draping techniques. Don't uncover them. And I would actually say to use this with all patients, not just these patients, but really definitely with these patients. Provide choices, but not too many choices. So not at every step should you say, do you want me to do this? Should we do this? Should we proceed? So a traumatized patient actually appreciates, which is basically my patient population, really appreciates when they know that I'm the captain of this ship and that I've established trust and I kind of know what I'm doing. They really appreciate that. So not at every step of the way should there be choices, but offer them when you can. Preparation, I think, is the most important part of the trauma-informed physical examination. It's telling patients what's going to happen before you do it, explaining it, and giving a reason for why you're doing it. I oftentimes will use some sensory examples. So for example, right before the genital examination, I'll say, okay, now we're going to get ready to check and use their terminology. Of course, I'm a pediatrician, so my terminology might be a little bit different, but we'll use the regular terminology. We're going to examine your vagina right now, and I'm going to spread or move the skin around that part of your body. And putting gloved hands on, this is what my gloved hands feel like. This is what you're going to feel. And you're going to then feel some pulling. I literally put my hand onto their arm and pull their skin. You are going to feel some pulling. What does that feel like to you? Pulling. Okay, that's what you're going to feel. So that's the prep. Then when we get to that part of the exam, positioning, again, really important to position without pushing legs down. So what I do instead of pushing legs down is I put my hands on the other sides of their knees and I say, can you touch my hand here? And then I follow that with, it's okay, I got you. So just like a reassuring sort of snap right at the end of them being able to relax. I know this is really hard. Let's take some deep breaths together. So a lot of times people feel like this just takes too long. I'm going to tell you right now, what I just did is literally what I do with patients, 20 seconds, and they are relaxed, and the exam moves much more quickly. So doing this preparation is really, really important and really important to incorporate into any type of training. Asking a patient before if they have any concerns or worries that they haven't already talked to you about is also very important. Of course, obtaining consent. So midway through, I'll check in and say, are you okay? Should we continue? That's also another way of sort of regaining consent. Okay, so the last R is resisting re-traumatization. So when patients come into the emergency department after a sexual violence, they are difficult patients for us for many different reasons. But I want you to consider that they are there because they actually want to do better. They want to recover from this. The fact that they actually showed up to the emergency department means they want this to not affect the rest of their life. They care about their body. And I always say this to people I'm working with, you get to be that person. So you get to be the person who actually helps them to recover from something that is so horrible. So it's really a lot of reframing when we think about re-traumatization. Really, really considering the words that you use in talking with patients. I'm just going to go back to referencing the patient that Lori presented. So the resident who called me said, first thing he said was she can't remember a thing. And so I thought to myself, then why are you calling me? Because how do you know it's a sexual assault, right? So there's something that she said about her vagina hurting. When she actually started to be less intoxicated, she started to remember. Oh, so she does remember. Why do you think she's saying that she doesn't remember? She might feel a lot of shame. So us perpetuating this narrative for her that she didn't remember anything is part of that shame. So reframing that for her by him going back and saying, it sounds like you remember a lot. Tell me everything that you do remember. And then the story sort of he's able to hear that story and the story comes out, or her history comes out, and he's able to use all of those other sort of positive things that are, wow, it really sounds like you remember. It really sounds like you couldn't consent to what you're talking about, also validating the fact that she was just sexually assaulted, because a lot of patients who come in really question, did that just happen to me? Really, is this happening? And so that external validation can be also really important. Just acknowledging the fact that someone has to retell this story over and over again by saying, I know that this is really hard to talk about. This is why I'm asking you this, because I'm your doctor today, and I need to take care of your body. So again, just resisting this re-traumatization is actually can be part of the process, but can be very healing for patients. Okay, so hopefully you're seeing that incorporating a virtual curriculum into emergency medicine training is absolutely doable, and it takes a village, but it's really very worth it. So as I think Erica pointed out where to access this virtual curriculum, but if you're thinking about creating your own, these are sort of some of the general thoughts that I had in my role in teaching, really, being sort of the trauma-informed trainer, I guess, was to think about other concepts that relate to a trauma-informed curriculum, which including multiple disciplines for the training, including a simulation model on a trauma-informed patient interview. Taking opportunities, so like with the case that Lori presented, always reminding the folks who are the organizers to take opportunities to reinforce trauma-informed principles, like in things like phone consultation that I had, for example, with that resident. Having a follow-up care program established before you set up the curriculum is really important, I'd say, for two reasons. One is because it's so reassuring to the providers in the emergency department to know that this potato au gratin, no longer a hot potato, something much better, is going to go to, she said it's like a hot potato, so something that's going to go to a provider who is trained to see patients who've experienced sexual violence. By the way, that really can make the person who's taking on that patient's care in the emergency department want to take care of that patient because they know that there's going to be follow-up care. Lori said this, creating educational opportunities and case reviews is also extremely important for not just the best practice, but also to reinforce for the people who are taking care of these patients. They provide, I don't have to convince you, we want to do a good job. We want to make sure that if there was something that we didn't do the best way, that there's an opportunity to learn more. And the very last point, which is I think one of the most important, is to ensure this collaboration between emergency medicine providers and Safe and Sanes. It is not, while this is a really cool image, it is not the image that we want for taking care of these patients. It's not passing the baton, it's really being in the boat together. So this virtual curriculum can be used for emergency medicine residents, for faculty, for advanced practice providers, and for nurses, and it should be combined with in-person simulation training. And with that, I have 24 seconds left, pretty well timed. We're happy to take questions. Thanks. If there
I've been trying to find I use the No Sane in Sight from the AIFN to have them do that as supplemental sort of online work, and then a case-based presentation. So it's just wonderful to see this resource out there. 11 hours is a tall order for, an intern, and all of our interns go through the training in our program. But I'd love to, just see more. And I guess I had a few kind of specific questions, but none of them are, relevant for the larger group. But would you say that's something you would be comfortable with my residents just coming on and taking?
The curriculum is available actually online, free to everybody.
Yep.
But I think there's room. We made it sort of Rhode Island specific, but
Yep.
there's ways to collaborate. I mean, we really love to collaborate to make it maybe national standards. There is no standardized curriculum for emergency physicians in the care of sexual assault. I mean, this sort of came out of the idea of there is a need. You can't abrogate your responsibility for caring for this patient, even when there's a sexual assault forensic examiner present, and there are a lot of places that don't have it. So what's a standard? What could be something that could supplement care, but also could be standalone? So, I don't know if, we haven't validated this as the absolute being, but there's definitely room for growth.
Sounds great. Were there other questions? I mean, I had that same issue with certification I run into a lot as a physician, because I'm not SANE certified, and I've done, hundreds of exams. And so I think, I guess my question is sort of if there isn't really a physician standard, like we do what we all, deem, that you're certified from our residency standpoint, but there really isn't a national standard. And so I don't know, especially in court, like when they ask our residents, like, well, my residency had certified me trained to do these, and so that's how we certify. But I'd love to get your thoughts on how that should look for folks, especially, the SANE nurses. Y'all have like a wonderful, robust program, and you're certified, but the physicians treat it kind of like a procedure. Like I'm signed off on central lines, like I'm signed off on this,
Like I know we have to end, but there is no certification for physicians or for providers. So, it's considered within the scope of practice, even though you may have received no training for us to walk a room and be expected to care for this patient. Whereas the sexual assault forensic examiners go through fairly rigorous training. So is there some happy medium where emergency physicians and providers who are experienced providers can incorporate this into care? And should there be credentialing standards? Those are all sort of questions that haven't been